Good afternoon, distinguished judges and audiences. I'm Li Dongzhuo from Team 23. Our topic is mannitol versus hypertonic saline for optimal osmotherapy of intracranial hypertension. These are our members. I'm an intensivist from Shanxi Provincial People's Hospital, Dr. Mi Baibing from Xi'an Jiaotong University, 6 medical students from the same school, and the software engineer Zhang Lei from Shanghai Dunchuang Information Technology Corporation. Next, I'm going to present the topic as the following orders. Brain edema and raised intracranial pressure (SAP) are some of the most common problems encountered in critical care. These problems are the consequences of acute brain injuries, as well as chronic brain disorders, including ischemic stroke, intracranial hemorrhage, traumatic brain injury, subarachnoid hemorrhage, brain infections, and intracranial tumors. It is recognized as one of the major causes of mortality. As this picture shows, there are generally two forms of brain edema, vasogenic and cytotoxic. In vasogenic edema, blood-brain barrier is disrupted. In cytotoxic edema, fluid will accumulate in the cell. In the bottom right is a CAT scan of brain edema. It is usually difficult to distinguish between vasogenic and cytotoxic edema, and most clinical situations involve a combination of two. This slide shows usually in clinical practice, we use mannitol or hypertonic saline to treat brain edema, and it's largely empirical. Until now, there are limited class 1 evidence to show which one is superior. One of the reasons is both drugs have several different concentrations, which comes with different osmolarity, as shown on the bottom of this slide. So it is difficult to design a clinical trial to compare the two unlimited cases of patients. Thanks to MIMIC data set, we have the opportunity to explore many unsolved questions about optimal osmotherapy in treating brain edema, especially for severe stroke patients, which is our main target this time. Next, we will briefly introduce more about mannitol and hypertonic saline. Mannitol is a potent osmotic diuretic. Its effects on SAP begin within minutes and last from 1 to 5 hours, depending on the dose. It has many side effects, including dehydration, hypovolemia, hypotension, hyperkalemia, metabolic acidosis, acute renal injury, and so on. Hypertonic saline is available in many concentrations and has similar osmotic effects as mannitol, but is a less potent diuretic. Repeated doses or continuous infusion of concentrated hypertonic saline leads to hyperchloremic acidosis and possibly AKI. This picture shows the vulnerability of organs in osmotherapy, which clearly demonstrates that kidney is the most sensitive organ in this regard. So in our research, we specifically investigated risk factors related to AKI and observed the impact of change of osmolarity and some electrolyte disorder on AKI and outcomes of patients. Our primary study endpoint is adverse kidney outcomes, and the secondary study endpoint is length of ICU stay in hospital deaths. Next, I would like to briefly talk about research method. First, we're mining in MIMIC-4 data for patients with osmotherapy, namely mannitol and hypertonic saline use. And in these patients, we focus on severe stroke patients who suffered from brain edema most, and analyzed under what condition AKI appears. The characteristics of patients and kidney-related data are researched in detail. And analyzed with these methods, we use post-SQL APG admin for data capture. This figure shows R scripts for data cleaning. Due to limited time, we have primary results depicted as follows. I'm sorry to say they are all in templates now. This table shows the baseline characteristics of patients. Next is hazard risk of acute kidney injury. And we are also working on dosing and AKI risk, and some subgroup analysis. Okay, next step. Next step, we are planning to stratify osmolarity during treatment and explore different levels of osmotherapy-related AKI, analyze electrolyte disorder and SEP rebound. That's all. Thank you very much for your time.